and welcome back to Health Watch. We've been talking to Dr. Ray Drugan about some common shoulder disorders, and I guess the one we all kind of aware of are rotator cuff tears. So people talk about it, rotator cuff injuries. I'm always amazed at the suddenness of that. I've heard people say, "Gee, all I want to do is reach something up to my top shelf, and all of a sudden severe pain, can't raise their arm." Almost a catastrophic, but it doesn't have to be that way. Talk to me about rotator cuff problems.
Yeah, rotator cuff disease is very common. Certainly it's the most common shoulder problem that I see. Typically we'll see this in patients who are age 40 or over. Many times it starts out as just a gradual onset, or it could certainly be a sudden event. Sometimes a traumatic event where they might have been lifting something heavy or fallen and all of a sudden they had a lot of shoulder pain. But many times patients just wake up with shoulder pain. They don't know what they did. Gradually gets worse and worse. Many patients will just think, well, this is going to go away, so they kind of watch it for a while, and months later or years later they'll come in because it still hurts.
Does it hurt with a specific type of movement? I mean, I always kind of think of it as certain limitations, but what do you see?
Well, the rotator cuff is made up of 4 muscles, and they all do different functions. The one that's most commonly involved is this one on the top called the supraspinatus. And what that does is abductor the shoulders, brings it out to the side. So most of the patients who have problems do have supraspinatus tendon involvement, so it hurts when they bring the arm out to the side or forward.
Right.
Many patients will also describe pain when they reach behind their back, but almost any direction can be involved. We used to call this, or we still do call it, impingement syndrome, although it's less commonly used. And we used to think that the impingement occurred between this bone on the top of the shoulder called the acromion and the rotator cuff, and that when patients would lift the arm, it would push that rotator cuff into the acromion. So we kind of blame that as the culprit, but we've found out that although that is the case in many situations, that probably more commonly it's actually a degenerative process. The vascular supply to the supraspinatus tendon is somewhat limited, almost right at the attachment to the bone. And sometimes what can happen is the tendon degenerates, it gradually weakens, and then can start to tear. So frequently it is a gradual progressive problem. And once it starts to tear, then the muscles here continue to pull. They keep basically pulling it away from the bone, so it retracts further and further. And then as time goes by, the tendon becomes thinner, it becomes less healthy, and basically poor quality.
Right. And you mentioned it can be a sudden event. That's just a
can
sudden
be.
tear.
Yeah, no, a lot of patients that we'll see will come in because they had a sudden event. They had a fall and they hurt their shoulder and come in. We find that they have a rotator cuff tear, and then we think, okay, well, this just happened as a result of their fall, but that's not always the way it is. Sometimes people have rotator cuff tears and they don't even know that they have them, and then it only comes to our attention when they've had an injury and a sudden pain. So sometimes we can get fooled thinking that this is recent and very fixable, and then we find out that this has actually been there a long time, and it could be more difficult to treat.
Right. And you can differentiate this from the instability issues yet? Is it basically, you talked about the age of the patient, give you some clue, I guess.
Yeah, that has a lot to do with it. More commonly after 40, it's rotator cuff compared to instability.
Instability, yeah. So that would be some of the issues. And so that you're just intuitively, I would think exercise is not the answer to this particular problem.
That's true, although it used to be that if we saw a patient who had a rotator cuff tear, we would recommend a physical therapy program. Then that progressed to the point where if you had a complete tear, we would go ahead and recommend surgery, assuming that this was a relatively active, healthy patient. The question used to be, what do we do with partial rotator cuff tears? Ones that only go partway through the thickness of the tendon. Those typically, again, we would put in a physical therapy program, maybe try a cortisone injection, medications, that sort of thing. But now we find that those tears tend to progress. They become full tears usually, and the tendon just doesn't have a good healing capacity on its own. So more commonly now, we will recommend surgical treatment even for significant partial tears.
Yeah, if you listen to the way you were laying this out, it's a degenerative process. It's not likely to get better on its own.
Correct.
Yeah. So talk to me about how then surgically you approach these.
Well, it depends which tendons are involved. Most of the tears are the supraspinatus, but the one in front, the subscapularis, can be involved, or the one a little further back, the infraspinatus, can also be involved. The more tendons that are involved, the more complex the surgery becomes.
Let me just ask a question. I'll interrupt you there, but are there diagnostic techniques other than your physical exam that you can do? I mean, certainly with the knees and even with hips now, you can't get away without doing an MRI or some other diagnostic technique that gives you a clue pre-surgically as to what the issues are. Is that true of?
Yes, we would always want to do an X-ray first, make sure that there's not any bony abnormalities. Of course, the rotator cuff won't show up on a regular X-ray, so typically we would do an MRI scan. MRIs, I think, are very helpful for diagnosing rotator cuff tears, but they're not 100% reliable. Some patients either have more significant tears than what the MRI might indicate, or sometimes it's difficult to tell the difference between degeneration in the tendon and possibly a small partial tear. So sometimes if the patients don't really appear on MRI to have a tear and we put them in therapy but they don't get better, then we'll still go ahead and do surgery. Surgery typically would be arthroscopic, where we would just through some small poke holes, put a scope in, look around all the structures, examine the rotator cuff very closely. We want to rule out things like frozen shoulder, adhesive capsulitis, or cervical disc disease, or degenerative arthritis, other things that might be causing pain in the shoulder. Once we think that it's the rotator cuff, and we would indeed see a tear of the rotator cuff surgically, then we would go ahead and repair that. Just look at this model here. This is looking at the shoulder from the front, and this red area represents the supraspinatus tendon, again, which is the most common tear. Typically, this tissue attaches to this part of the bone called the greater tuberosity, and when it tears, it gets pulled away from the bone. The muscle keeps pulling on it, so it continues to retract further and further from the bone. So we go in with an arthroscope, we look at that, we have several different working holes where we have small instruments where we can grasp the tendon, free it up, release adhesions that might be keeping it tight back here. And then we have a variety of different methods to sew the tendon back to the bone. First, we would roughen up the bone to stimulate some bleeding and healing potential. Then this is secured to the bone, and that looks something like this. This is just one technique that we would use where we would put these similar type of anchors into the bone with a heavy suture that is then just one technique where we can crisscross these sutures over the tendon and pulls it flat against the bone so that eventually they heal to each other. Again, this is a slow process. We used to start moving the shoulders pretty quickly after rotator cuff repairs, but we found that the biology of healing is a little slower than we thought, and when some reevaluations were done, we found that they actually re-tear more than we used to think they did. So we've actually slowed down the physical therapy.
Yeah, we're going to take a break again, and we'll come back to this. We're right back at this message.